aware what fetal therapy is. So I just want to sort of go back over a couple of principles about that. So fetal therapy is basically therapy that's intended for the benefit of the fetus. Fetal therapy always has to go through the mom because the fetus is within the mom. And if we're thinking about the treatments that we administer, they sort of fall into three categories. One is where we're trying to prenatally actually cure the baby so that the baby is born with the same chances like a normal baby at birth. Then there are some other conditions where in the intrauterine environment, having a lesion actually damages the baby progressively, and if you don't do anything prenatally, the baby is born with some irretrievable damage. And so here are sort of therapies where we try to alleviate that. And then there are some other circumstances where you can't do anything prenatally, but just by optimizing the delivery circumstances and the delivery timing, you still derive a benefit for the baby. So that's also the treatment categories. So when we think about fetal therapy, it's worth thinking about, well, how do we actually reach the fetus? So medical therapies, you can give the mother a tablet. It'll go across her circulation to the baby. But all surgical treatments somehow have to get into the uterus. So we have to get to the mom, to the abdomen. There's organs there. And then we have to get into the uterus. Now, to get into the uterus, you basically have to go through the skin of the mother, the subcutaneous tissue, the uterine muscle, the potential space that exists between the amnion and the chorion. And the amnion is essentially the sac that the baby swims in. And that's the sac that retains the amniotic fluid and is basically the fetal environment. And it's a thin membrane that has no healing capacities. And then there is the placenta where the baby derives nutrients from. And in fetal life, nutrient delivery is basically blood flow from the mom to the placenta and blood flow from the placenta to the fetus. So essentially the placenta is a huge lake of blood that gets about 2 liters a minute of cardiac output from the mom. And so you really don't want to go into that organ, right? And then the other thing that's a very fundamental thing that a lot of people don't think about, we sort of think about brain tissue, for example. We know that if somebody has a stroke, they may not regain normal function again ever because brain cells typically don't have the ability to regenerate themselves. Well, the amniotic membranes, which basically form the encased environment of the fetus, also don't have the ability to heal. So once a hole has been put into the membrane, that hole will be there. And here are, holes from operative feedoscopic surgery that we have performed at 23 weeks. And this is the membrane at the time of delivery at 39 weeks, right? And the only reason why this patient didn't break her water is because the amnion, this membrane, remained stuck to uterine muscle pretty much like wallpaper and didn't allow fluid to come in between there. So anything surgically that we do into the uterus, we have to be careful of the blood flow that's in the placenta, the blood flow that's in the uterine muscle, and the integrity of the membranes. The amniotic fluid is the environment of the fetus. That's sort of its properties. It has some other properties that are beneficial for healing, such as stem cells. It has some antimicrobial properties, the zinc mucopolysaccharides. It has hormones in it, and it has desquamated fetal cells in it, which is what we use to determine the genetics of the baby. And that's what most women that have been pregnant are familiar with. So how did prenatal diagnosis start? It started with being able to do genetic testing on the baby. And so the simplest procedures are ultrasound guided needle procedures. And so what you do is you look with the ultrasound, here you see the needle coming in, you draw a sample, and when you're done, then you are withdrawing the needle again. Now, these needles used to be spinal needles, and as you can see the tip quite well, and that's because the tip, the surface of the needle is agitated, so it reflects ultrasound, so that makes it possible to direct the needle pretty accurately, so we can sample from within the placenta, or we can sample fetal blood, so this is where the needle goes into the umbilical cord, right? And then we're putting some blood into the cord. This is for fetal blood transfusions. And that's really how fetal therapy started. These needles are somewhere between 18 gauge to 22 gauge needles. And the considerations when we use them are basically that an 18 gauge needle puts a larger hole into the membrane, but it has more directionality. A 20 gauge is a little bit less rigid, and a 22 gauge is quite floppy. So when you have a big distance to go, you won't be able to direct it accurately. So when you're planning needle procedures, it's always a trade-off about the required accuracy in a particular patient and basically the diameter of the injury, right? So when you think about narrow gauges have the advantage that they are less invasive, they're smaller holes in the membranes. They will allow easier vascular access. And so where we've been exploring this is for stem cell transplantations, right? So there are some diseases in the fetus that you can cure with a stem cell transplant. But what you need to do is you need to access the fetal circulation early on, because before the baby has immune competence and rejects a graft, and also that the dosage of cells is calculated for the fetal body weight. You know, a 14-week fetus is a lot smaller and requires less stem cells and all that. So there are some real therapeutic advantages. There are no needles that meet those needs. And the problem is that, you know, at 14, 15 weeks, the amniotic membranes are even more vulnerable. So the way that we get around this is that we sometimes use a 20 gauge and a 26 gauge needle through that. The 20 gauge is used to brace the needle because it's not that floppy. And then for the last piece where we need to get into the circulation, we use the 26 gauge needle. These are actually not needles that were designed for anything fetal. They come from anesthesiology. So like, that's the recurring story of this talk. You have to borrow devices from other people. And if you're smart enough to know what is available in the hospital, you might sort of abscond some equipment and use it for your benefit. The narrower gauges have the disadvantage also that they may, you know, produce collateral damage because you can't direct the needle, so you end up somewhere where you don't want to be. And they might mechanically destroy red cells. Obviously, the lumen of a needle can only be of a certain width before the, you lose the stability of the needle. But I'd often wondered if there are any materials that might actually be just more sturdy to use for these kind of interventions. Now, moving to the next kind of procedures, so ultrasound-guided shunt procedures are the next thing. So here are some ultrasound images. This is a baby where there is a large pleural effusion, so a fluid accumulation in the chest that is pushing the heart all the way out of the way, and this baby is going into heart failure, and if you don't drain this, the baby will die. Here is another lesion where you have a large cystic tumor in the thorax that has a similar effect. And here is a 3D ultrasound image of a baby where the bladder is massively dilated. This is the first part of the urethra, and here is where the block is. So the baby's kidneys are producing urine that can't get out into the amniotic cavity. And because of that, there's no more fluid around the babies, and the kidneys are being damaged by the back pressure. All of these kind of conditions share one therapeutic avenue in common, which is basically that you put in a diverting shunt. And these are typically inserted under ultrasound guidance. These shunt introducers are larger than needles because something has to be passed through them. And once you are in there, you deploy the shunt. And what you see on ultrasound, these double echoes, is basically these pigtail shunts. In this image, you can sort of make out this is the bladder of the baby. Here are two coils of the shunt, then the straight portion, and then the other loop outside in the amniotic cavity. So what this does, it bypasses the obstruction. These shunt introducers were made for fetal medicine and predominantly in Europe. So this first shunt introducer came from England, and it still comes from England. It's a double pigtailed shunt. The introducer is about 2 millimeters in diameter, and this one is done by Cook Medical in the US and subsequently was brought here. These shunts are actually still under regulatory oversight by the FDA, and you have to have some approval process with the company to obtain these shunts. Sorry, I'm getting a marketing call. Maybe it's a medical company that wants to sell me some new shunts. No, joke aside. But anyway, so the advantage of shunting is that it can prevent further organ damage and temporize until definitive cure after birth. But the problem is that the baby is a living human being. So what it does is it feels something in the belly and it pulls the shunt out, right? And so, and about 2/3 of shunts fail for that reason. So the baby pulls it back out again. So, and repeat procedures, because you're doing repeated holes into the uterus, increase the obstetric risk. So you could bypass that by having maybe a smaller gauge instrument, and there is another shunt available that's delivered through an 18 gauge needle that's made out of nitinol, and it's very similar to the Amplatzer kind of vascular arrangements, like the wire kind of like a Chinese finger and all that. So if you do a repeat shunt, then you're just putting an 18 gauge in, and that's not as risky for rupture of membranes as a 2 millimeter shunt. Or what you could do is you take a microscope, like a small instrument, and do the definitive cure by a surgical procedure. Now, the problem with that is that this is not available in the US, and this is just a tad too big and not suitable for intrauterine access. So this is a pediatric uroscope. It has a working channel. It can be worked around and all that. But when you start bending the tip and if you were to put it into fetal bladder, it would get against the wall and all that. It is really not well designed for that narrow space. So we do fetal cystoscopies because we have recognized that you can't necessarily see by ultrasound what the problem is. So this is a case where there is no urethral opening, and this is a fetus at 19 weeks, and we went in with an optical instrument. Here we're trying to pass a guide wire through to see if there's actually a patent passage, and there isn't a patent passage. This is a cystoscopy at 17 weeks where we're looking in, and here you can actually, I'm just going to stop this actually, swing. So here what you can see is there is a little sickle here, right? A little, I don't know if you can appreciate that. So there is one edge here, there's another edge there. What this is, it's a tissue that's called the posterior urethral valve that overlies the urethral opening, which is over here, and is basically, if you were to put a hole into this or you laser that, then the urine could freely drain. So this you could actually cure prenatally. And that's why we end up doing cystoscopies to look into that, right? Now, how did we do this procedure? Well, what we did, we actually stole some instruments. So what this is done with is, it's done with the Harrison shunt introducer, which has an inner diameter of about 1.5 millimeters. And then it's done with this instrument, which is an angioscope. Now, angioscopes are basically fiber optics that can be used to look inside blood vessels. It has a working channel here, so you can put something through it. And it's 1.3 millimeters, so it just fits in there. But the issues are that you can't manipulate anything active, right? And so what you have then is you have a needle that is in the bladder, and you have the scope out there, and then you have to manipulate it into an area where you can surgically fix what you want to fix. So it really is more beneficial for visualization, but it has very limited role for surgery. So that's why we really don't use it anymore, because it's really frustrating. And the other thing is the working channel is so narrow that you can use only a very limited amount of guide wires and all that, and they're just not rigid enough to even, puncture a small little tiny membrane like you saw in that video. So this is a real issue, because urinary tract obstruction in the fetus specifically is a horrible disease, because babies die after birth because their lungs are underdeveloped. And if they happen to have enough lung function to live, then they die from renal failure, in the interval. So that's, an example where things don't work very well, and we tried really everything that we could. Now I want to switch over to twin-twin transfusion syndrome. So this is a placenta, and this is a placenta in identical twin pregnancy. So here you have the cord insertion of one baby, cord insertion of the other baby. Then you have vessels that have been injected, and you see that here is a vessel that comes from this cord insertion that connects with the vessel from this cord insertion. So these vessels allow blood flow from artery to this vein over there, and these are artery to vein anastomosis, they are artery to artery anastomosis, and then where their connecting points are is the vascular equator, and that defines how much nutrition each baby has access to. The diseases that come from unequal sharing of placental blood flow or placental size are twin-twin transfusion syndrome and selective growth restriction. And these happen only in identical twins. They are not recognizable other than with ultrasound. And if you don't treat them, the mortality is exceedingly high. In twin-twin transfusion syndrome, over 90%. In selective growth restriction, somewhere between 15 to 20%. So it's a pretty bad disease. Twin-twin transfusion syndrome is diagnosed by ultrasound by demonstrating unequal amniotic fluid volume in each sac, and it has diagnostic and staging criteria that allow it to prenatally assess the severity. So the way that we treat TDTS is that we do fetoscopy, that's operative. So here you see two babies. When you notice, this one is a little bit clearer. That is the baby in the sac where there's a lot of fluid. And the other one is a little bit obscured. These are blood vessels that go from the surface of the placenta, from the cord insertion and run. And then you see here they're starting to connect with other blood vessel connections. This white line is the membrane that's folded over that placental side. And then we basically go in with a laser fiber, and that's a YAG laser or diode laser or KTP laser, and we basically occlude these connections with the ultimate goal to convert this into a placenta where along the coagulation line, they're independent of each other. And with this, I mean, at the center, we now achieve double survival, like neonates going home, of about 77, 78%. And so that is now the standard of care, if it's available, if the technique is available for TDTS. And here's sort of like a family that I delivered, after having successful laser surgery. Now, just about the equipment, right? So when you do fetoscopic surgery, you basically have a visualization instrument, which is your fetoscope, right? They can be straight fetoscope where the eyepiece is on it, or remote eyepieces. And these are basically fiber scopes. That means these are glass fibers like 30,000 to 50,000 that are packed very tightly and therefore kind of like transmit the image analogous to the eye of a fly, right? They have slightly less resolution than a rod lens scope, and a rod lens scope is basically an array of lenses. The smallest that they're available is in 2 millimeters, because under that is really hard and expensive to work the glass. And then in these attachment pieces, you basically have a light source just with any other laparoscopic surgery, and it delivers light there. They are available in different visualization angles, so 0 degree and 30 degree. The video that you saw earlier on, the placenta here is basically in the front, right? So when you kind of go here, that is up top. So in order to see that, you need to use a 30 degree scope, right? And that's basically one here where you kind of look up. Then you have an operative sheet. So the fetoscope is inserted into the operative sheet, and through that operative sheet, you can insert all sorts of instruments like a laser fiber. If there's a microsurgical instrument that you can do that. And the operative sheets can be passive, so you just put something in, or they can be active, where you have here this mechanism where you can reflect the fiber up. This is called an alburam. So one of the things that's the bane of our life is these attachments here, they are at non-standardized angles. So sometimes they have such an angle that certain instrumentation you couldn't actually push through it. Whoever planned that is beyond me. It makes no sense whatsoever. And in some cases, these channels on the inside damage the instruments so that we have to use multiple laser fibers because the tip is broken up and it affects the precision. The other thing is these instruments are very, very delicate. And so most of them come with standard containers, or specialized containers are very, very expensive or not available everywhere, so that there is a pretty high rate of destruction in the sterilization process. And because they're very specialized instruments, many times people may not be aware of what this looks like normally, right? And so they don't recognize when it comes to the OR that it isn't working properly. Now, the insertion of these sheets into the uterus can be done directly. So some of them have a sharp pyramidal tip, or you use a flexible cannula, and this is a Cook vascular sheet. So this was not at all designed for fetoscopy ever. But what we use is we use 10 to 12 French of these sheets. We have metal obturators with a cutting tip. And depending on the type of fetoscope that we use and the diameter, we will basically use these to go into the uterus, particularly if you want some flexibility. The problem with all of this instrumentation is there's almost no cross-compatibility. So if I know that a patient has a placenta up on top, and I want to use a 30-degree sheet that I need to do that, then if I wanted to switch to a 0 degree to just look somewhere else in the placenta where I may have seen something that I can only see with a 30-degree, you can actually put those into the sheet. So all of these sheets, they were kind of developed for dedicated procedures rather than with the thought of saying like, okay, we want a multifunctional fetoscopic operative sheet of size X, Y, and Z, depending on the gestational age, right? So that is a real challenge. Now, the other procedures that we do in complicated twins is cord coagulation. So this is basically where we clamp the cord. This is done with bipolar grasper forceps, where we have to use ultrasound guidance to make sure that things are placed properly. The outer diameter of these is about 3.5 millimeters, and they basically come from laparoscopic surgery. There is a version of this that's been developed in Europe, where you actually have a lens that looks at this so you can actually see what you're coagulating. That is not available in the US, so here we have to go with ultrasound guidance. The other alternative is to take other coagulating devices such as microwave needle or RFA needles. These come from tumor surgeries, or tumor ablation, and we typically take the smallest needle, and we are very successful with that. So again, it's not that the equipment is horrible, but the equipment that we use wasn't necessarily designed with our needs in mind. Now let's go to another disease, congenital diaphragmatic hernia, which basically is a condition that damages the lungs by having other organs in the thorax and compressing the lungs. And this abnormal development in the lungs basically lead to abnormal lung function at the time of birth. And the smaller the lung, the less likely survival. And babies with, a severe diaphragmatic hernia without any fetal therapy have a survival chance that might be well under 30%. So the basis of fetal treatment is based on the observation that if you block the trachea for a period of time, the lung fluid cannot escape, and that builds up backwards pressure and reverses some of these damages to the lung that occur from compression. And it's taken many years to get actually equipment that you can do temporary tracheal occlusion. And the feasibility studies have shown that the survival can be at least doubled with that. And in right-sided CDHs, in this study, the only chance for survival is actually this balloon treatment. It's important to recognize that before this was available, there was even open surgery or clipping of the trachea and things like that done to do diaphragmatic hernia treatment before birth. People were that desperate that women went through open surgery because the disease has such a bad outcome. Now, this is a purpose-developed scope, and what that means is this was developed, this is based on all other fetoscopes that we use, but there are some modifications that make us a different scope, and that means that it goes under different regulatory entities, and in order to use it in this country, you need an investigational device exemption to even bring it in here. And through that working channel, we put in a balloon that used to be available in the US for blocking of brain bleeds. So this is a latex balloon that gets inflated and then detached. The company that held the patent sold the patent to a very large company here that has been buying multiple biomedical other companies. They have decided to table the patent and are no longer producing that, so we have to get a similar product from France, also under an IDE. The approval process from the FDA to get this into this country has taken us 8 years. So just to give you some perspective. So we have just published our results here, and this sort of illustrates the relative lung size of babies when we're doing the tracheal occlusion. This is the mouth of the baby. This is the 1.3 millimeter scope, and using that sheet, there are some well-described landmarks. That is the midline of the roof of the mouth, and then we basically work our way back. This is at 28 weeks, so this is done by a fetoscopy in a 28-week fetus, and eventually we sort of flush with some saline. We get to the back of the mouth where we see the uvula, and that brings us sort of into the back of the pharynx. And then we see the epiglottis, and when we go just behind the epiglottis, that's where you find the arytenoid muscles. And if you then go forward, that's where you will see the vocal cords and the entrance to the trachea that we then enter with another sort of flush. And then we deploy the balloon in there, and then it stays in there for about 5 to 6 weeks. So these are the tracheal rings. It's always a very gratifying moment, and the baby is paralyzed and anesthetized during this, and then we're advancing the balloon, and then through the deployment catheter, we're basically putting 0.8 cc's of saline in, and then pulling off the deployment catheter, and the balloon will then stay there for 6 weeks, and then we remove it again. Once we put the balloon in and you do ultrasound, you see growth of the lung. So on average, the lung will about, almost treble in size. And then we have to remove the balloon, because when a baby needs to be born, then it needs to be able to breathe. And we do that either by repeat fetoscopy or by an ultrasound guided puncture. And then the lung gets smaller again, but by and large, the size is in a much less severity range than it was before the procedure. And at Hopkins, we have had some very favorable outcomes where these hernias that were basically very severe, had almost no diaphragm on that side, had a survival until discharge from 86%. And that's actually the highest survival that has ever been reported for these kind of patients. So again, an example of none of this was ever made for fetal therapy, and you have to be really inventive. So I'm going to go, I think this is my last sort of intervention business. I don't know how we are for time. Okay, so
we're good for time.
Yeah, okay. So spina bifida is another disease where there is prenatal damage and loss of function that is, irretrievable after the baby is born. So the idea that was, presented, and some of that research actually comes from Hopkins, is like, well, what happens if you prenatally achieve a watertight closure of this defect? And that was studied in a randomized trial that employed open fetal surgery. That means you do a laparotomy, you incise the uterus, you bring the baby out, fix the back with a pediatric neurosurgeon, then put the baby back in, and then from then on, the mom will always need a cesarean section because you damaged the uterine muscle. But what this trial determined is that hindbrain herniation, like the pulling down of the brain that is responsible for the needs for shunting and all that, was significantly reduced, to about 20%. The neurologic deficit was far less, and babies were more likely to walk. So for patients that meet a certain severity criterion, this has become the standard of care if you can offer it. Now, because when you're doing this open fetal surgery, you're damaging the uterus and you have a lot of obstetric risk from that, people have explored the ability to do it feedoscopically. And Feedoscopic Mmc Repair was pioneered actually in Germany by Thomas Kohl, and then by Denise Pedreira in Brazil. And basically these procedures, they share the benefit for the fetus, but they differ in their maternal risk. So the open surgery has significant maternal risk. Babies are delivering at 34 weeks. There is about an 8 to 10% risk of spontaneous uterine rupture in the same pregnancy or in future pregnancies. And in some of these cases, the baby dies because the cord is trapped in the ruptured uterus. The problem with Oh, this is actually German, if nobody noticed. Percutaner fedoskopischer Verschluss. That's funny. It's the same. It's a percutaneous fetoscopy. So the problem with this approach is that it takes about 3 to 5 hours. Delivery is early, and the reason why that is that over 60% of patients rupture their membranes, but it has the benefit of avoiding maternal obstetric morbidity. So, sorry, I may have to just look at, I'm going to go forward and I'm going to go back again. Okay. Actually, no, I just go straight through this. This is better. So, can you still see the screen?
Currently, we're seeing your video camera.
Okay.
And now we see your screen.
Yeah, okay. So this is an example of a port that's in the uterus, okay? And you see this running here, right? And I give you a hint. This is the placenta. This is the fluid. What do you think that is? Anybody?
Blood.
Yes. It's bleeding from the edge, and you know, there is really no way of compressing that. Like when somebody bleeds in the abdomen, it happens all the time. You can just put your finger on it and you're fine. So with the port being this way, there is really no good way of fixing that. And here, what you see a few days later, the baby is still alive, but there's sort of like a blood clot floating there. So you can get problems from the uterine entry that cause bleeding. Now, that's not as common because we can scan with ultrasound and detect blood vessels. But one of the more common problems that we see is what you see here. So this is the uterine muscle. This is amniotic fluid. This here is the amniotic membrane. And what I talked about in the very beginning, this membrane is stripped off the uterine wall and there's fluid here. Now, when you have membrane separation like that, it's basically a precursor to rupture of membranes. So the majority of patients will deliver preterm. And so when you have beneficial surgery and you have these obstetric risks, the prematurity related risks potentially really, you know, take away the surgical benefits. The problem is for fetal surgery, there are really no good trocars. Most of the trocars that are used in surgeries, they are designed already to sort of keep the layers together. So you have this kind of mechanism where you screw something in, or mechanisms where you pull something up, or you can have a balloon like this. But these trocars are all 5 to 10 millimeters in diameter. If you remember, 3.8 millimeters is probably the largest that we like to put into the uterus. And what happens now if you take the vascular sheets that we use, in a course of 3 to 4 hour surgery, you're moving this in and out, sideways, left and right. And what that does is it shears the membrane off the uterine wall. And with that, amniotic fluid can enter behind and it just strips it right off. And this is the reason why percutaneous spina bifida repair has an earlier delivery time, although it is actually safer on the uterus, because women break their water and then eventually go into preterm labor. We have done feedoscopic MMC repair, but because of this issue with separation, what we do is we actually do open MMC repair. Or open laparoscopic MMC repair. So this is the baby's spina bifida defect, and this is now the important step. What we are doing is we're suturing the membranes to the muscle, and then we're putting the port in through that, and we're shortening the port. But because the membranes are plicated against the muscle, they actually don't come off, right? And so you can operate for 3 hours, and at the end, the membrane integrity is still preserved. But of course, what we need to do is we need to still do a laparotomy. So, I mean, what would be ideal would be a port that does that, right? I mean, that sort of self-plicates itself. So these are sort of the surgical steps. And all of these instruments that you see have nothing to do with fetoscopy. They're all laparoscopic instruments that we are using under an IDE for this procedure, right? And including the suture cutters, that I think that comes from orthopedics. So none of this equipment was ever made for fetal surgery. And this is sort of what the back looks like at the end of the surgery. And then this is at the time of delivery at around 39 weeks. The advantage is these babies can deliver vaginally and the women have a normal reproductive future. So what are we using here? This is a 6-degree laparoscope. That's the only one that we had that was short enough. It has a central working port. We use standard graspers.
Because we dilute it.
And then we use these graspers. They are 4 French. They are pretty flimsy at the tip. Better graspers are available just at 5 French, but the inside port is just a hair too small for them. So we're struggling with these really flimsy instruments, and the second port has the better operative instruments. It would make it a lot easier to have something that you could rotate and that would use the integrity of the working port as a support structure and therefore allow to use even a smaller diameter instrument. Now, we've been very successful with this technique. Our average gestation age at delivery is, just under 37 weeks, which is good, and our shunt rate is now, I think, about 15% or so. These complex procedures where we have to sort of modify existing equipment, we're basically doing that with a simulation program in the center. So this is a very high fidelity kickball that we use. This is the size of the uterus. And here we use 3D printing from ultrasound to create the lesions that we then operate together to go sort of through the surgical steps. So just want to finish up with some of these regulatory aspects. Because the uterus is a high-risk environment, unless a device has been marketed for that, really you have to, according to the FDA, you have to use an investigational device exemption, which is basically, it has a regulatory component with the FDA where they have your protocol, how you're approaching things. It specifies what you report on an annual report and the adverse events that require immediate or intermediate reporting, and you have an accompanying IRB protocol that is basically matched, right? When safety and effectiveness or feasibility with a device have been documented, but it's still required that you have ongoing monitoring of the safety because it's high-risk procedures, you can have a humanitarian device exemption. And this is what we have for our feedoscopic equipment, which was basically introduced into the country about 2000. Before that, we were using hysteroscopic instruments that were used for vaginal surgery on the uterus. When a company decides that they want to bring a high-class or high-risk device to the market, then they can go for pre-market approval or 501(k). And basically the difference is then that the regulatory component allows you to purchase that device for the intended use, right? And so what we are doing is with all of these things, we're doing off-label use, right? Now, I've had countless discussions with, medical companies about helping us with developing instruments, right? And they basically say, well, fetal therapy is a niche field. Well, I think that's actually a fairly short-sighted perspective, because if you think about it, as far as operative risk, we're operating in one of the most challenging environments. The patient is in its own environment within another person, and you need to keep all of these safe and have reproducible, safe surgical outcomes, right? And that sets the bar of what the equipment should be able to deliver really, really high. But if you think about it, if you are able to build a modular or whatever you want to do that, an equipment line that says like, okay, here's a small diameter access, middle diameter, large diameter access across the gestational age spectrum, where all the working channels are standardized, the lighting sources are standardized, the visualization is standardized, and there is no more problems with cross-compatibility. I think that if you can bring microsurgery successfully into the womb, it's going to affect positively any surgical specialty that utilizes miniature techniques. Because if you can make it in the uterine environment, as they say with New York, you can make it anywhere. So thank you very much. That's the end of my presentation. Thanks.
Thank you very much. Thank you very much, Dr. Baschat. Well, I have to say, as I'm sure anyone who is naive to this surgical specialty, it's just really astounding. And I'm sure you hear that all the time, but I can't help but tell you just how amazing and astounding the work is.
Thank you.
So I certainly have many questions, but I want to first welcome questions from the attendees. You can raise your hand or just unmute your microphone. I see Chuck Montague has posted the link to the survey. Thank you, Chuck.
No, not the survey. Not the survey yet. That's a link to the recordings.
I see.
The survey later.
Okay, thank you for that. Then I'll start, but I do welcome questions from the group. Let me ask you about training. Actually, you showed the use of 3D printing. In fact, I think we printed a spina bifida model a couple of years ago.
Mm-hmm.
How much? I mean, the idea of training in this specialty seems especially challenging generally, and for a patient-specific.
Down. I'm on the Zoom. Sorry, I'm at home. I just had to.
No problem. But it does seem difficult, both generally and on a patient-specific basis, where you might like to train for a particular variation before you're in situ. What are the innovations in training? It just seems like a really challenging area of surgical training.
Well, I mean, I think one is really using simulation. So there are a couple of spina bifida lesions or fetal tumors or things like that nature. They are challenging because they vary across patients, right? The lesions are not the same. So that's where patient-specific learning is very useful. I think for the other techniques, there's some very principal things that you can teach in any simulation thing, right? And then, so the training, there's a lot of apprenticeship in it. And, so when you have a good patient volume, you need to have time to discuss all the strategies beforehand. So there's a lot of things that I think about that the fellow may not think about. And so it's that learning by doing component. We have a simulation card set up so that we can, just understanding the equipment, right? Because every equipment, I didn't go into that, they all have their quirks. There are certain things that you cannot do because you won't be able to get your stuff done. So for that, simulation is very important, So I think it's case volume, discussion, simulation, and patient sort of individualized learning. The other thing that we've done is research into standardizing surgical access, right? So the placenta is completely random. I mean, you don't know what it looks like and you can't see it from the outside. But we have devised a technique where it's like when you look at 3 ultrasound landmarks, you're always going to pick the right entry point into the uterus to see the whole equator, right? And we tested that between trainee attending, old attending, and some other people that participated, and the agreement and accuracy is 95%. So that's sort of improving the technique. So we are very cognizant of that,
Okay. And then a somewhat related follow-up question. You did a really good job of describing the cobbling together of instruments from other areas, whether it's neurosurgery or orthopedic surgery or whatever. So how is that cobbling together communicated across the field in any kind of standardized way? How does that, or is every doctor and every patient kind of a different sort of custom solution? And it seems like that would mean that the quality of surgery really varies a lot from center to center.
Yeah, so publications.
Yeah.
Like you basically say like, okay, we've done 10, 15 cases. We just published our spina bifida series where we go also into the process of setting up the program, right? Mm-hmm. So we don't just talk about the surgery, because that's a little lame actually, because it's more important to say like, well, we started from zero, right? Like we never did those kind of surgeries here. And so we published about the process as well, because that's important. How do you get there? And then working in a place like Hopkins where you have millions of subspecialties, that's very helpful. Because if you go to an orthopedic surgeon and they come like, why don't you use this? This works great. And you're like, oh, what size is it? Oh yeah, it's only 1 millimeter. Sure, we can use it. So a lot of this is like, and then you just call the FDA, put it on the list, and it is then on your instrumentation list. That's how it works, actually.
Sort of I guess how I do it papers are important.
Yeah.
So I have a technology question and a regulatory question, but I don't want to take all the time. I see lots of clinicians. I said I'm naive to the field. Maybe there are some more expert questions from the group. Anyone from the audience, a question?
You guys can also email me.
Go ahead, Dr. Lena.
Yeah, so thank you so much for that excellent talk. Seeing all the instruments that you use really reminded me of some of the instruments that we use in otolaryngology as well, especially for pediatric airway. Silentoscopy is probably the smallest caliber. I'm just wondering if you could comment on your experience in sort of crossing fields and seeing what tools we use. And likewise, I'm looking at the tools that you use and thinking about different ideas for things that we can do.
Yeah, so we don't really have a microsurgical think tank. And I think that would actually be a good thing to do, where you say like, okay, let's get people together that work in small spaces. In general, the problem with intrauterine surgery is you don't just have to achieve your surgical goal, but that's your only channel to deal with complications as well. If you get uterine bleeding, you need to have an irrigation that is immediately working. If this happens, so it's so like as far as scopes are concerned, there are falloposcopes where you can look into the fallopian tubes. They're microscopic. First of all, you don't see anything because it's looking like at the Eiffel Tower from an ant view, and they are so flimsy that like you can't do anything with it. So something being small isn't necessarily enough. But I'm always curious when I hear, oh, we do this, we use this surgical equipment, because also from the provider, like the companies, they don't give you a lot of advice what's available. Like the OBGYN rep doesn't know anything about the urology rep, right? So I'd be very interested to meet up and talk about what you're using, Does that answer your question?
Yeah, I definitely agree. I think, conversations like this are so important, and I think they don't happen frequently enough.
Yeah.
I don't suppose that ophthalmology would be relevant to a think tank on working in microsurgical spaces, or is that another scale altogether?
I don't know. See, I believe you can learn something from anybody, right? Because it's the perspective. Somebody says, like, oh, we're doing this with a laser, and you're like, oh, that's what you use it like. We could use it for that. You know what I mean? So I think there is never, like, there's always an opportunity to learn, for sure. You know?
Great. Could I ask, is there, just out of curiosity, is there a role for ablative technologies like Haifu within fetal surgery?
What technology does that use?
Oh, it's a high intensity focused ultrasound technique, which is transcutaneous.
Yeah. I've looked into that a long time ago when it came out for fibroids and all that.
Yeah.
I honestly don't know if we have a machine, but where it would definitely be helpful is placental tumors.
Okay.
And fetal tumors. I mean, we had some babies like miserably die because the tumors just exploded and just, you know, so that would be very awesome, because if you do microwave, you're still in there, you could get bleeding and things like that. That would be pretty good. But do you have one lying around? I mean,
Hopkins, I don't want to misspeak, but I don't think we have the biggest Haifu center of other major medical centers, but we do have some Haifu going on. Yeah,
that's great.
And it's MR guided or ultrasound guided. Yeah,
our microwave comes from a different department. We just borrow it. You know, we just say thank you and then we borrow it. We didn't buy our own, so we do that. You know, interdepartmental.
Okay. Yeah, I think we could be doing more. I have one more question, but we have time for one more question as well, so I want to give anyone else the last if they want it. And mine's a regulatory question. So IDE and HDE, it seems like that's the norm for you, even for a device that is marked or cleared in Europe. Yep. Is it the same hurdle whether a device is marked in Europe versus a device which maybe you have modified or is yourself?
Yeah, so I tell you, strictly speaking, I have a pretty good connection with the FDA, so I know my section. If you modify anything, it needs their approval, but not everybody does it that way. I mean, I know that there are some fetal therapy centers that have modified equipment that was never reported, right? Mm-hmm. And so, I mean, if you modify something, you need to report it for sure.
Well, where is the control over the practice of medicine, FDA? And I know plastic surgeons do a lot of modification. Is it because of the high risk of the fetus?
Yeah, because the uterus is considered a high-risk environment. But when we did the started the spinal bifida program, we asked them, could we just do it as a treatment? And they said, like anything where you use stuff off-label, you have to have an IDE because the uterus, by definition, is a high-risk environment.
Well, you must have a great relationship with FDA, almost a hotline. I mean, how is that managed within the routine?
Well, one of the things that's challenging from a clinical perspective is that the hospital and Hopkins does not recognize that even if we just offer things clinically, we have a significant regulatory burden. So that a research nurse or a regulatory specialist is actually required to run our center, even if we didn't do a single piece of study, right? And that requires financial support, right? And that's been one of the big challenges that I just say, like, I can close the spinal bifida program if we don't have a research regulatory specialist who usually is a research nurse, right? So it has, like, by default, there's a regulatory, and it's intense. I mean, when you do a case, everything is recorded, like the minutes you took this, when you did this, if there was any bleeding, any adverse effects, that's all recorded for every patient.
You said at Hopkins, how is it done elsewhere?
Well, I mean, I know that other centers have that as a fixed part of their fetal therapy center, you know. So fetal therapy centers, that's a different discussion, but They could be housed in the pediatric surgery department, in the pediatrics department, or an OBGYN department. And I guess the leverage that these departments may have financially may differ, you know?
You know, you described the financial challenge to companies to innovate in this space, but I like how you turned the tables. If you can do it there, you can do it anywhere.
Absolutely.
But, you know, the financial challenges in this field are real. And I would add one more, you know, because I'm an academic researcher in an engineering department, you know, and my colleagues and I, we, you know, the kind of problems you described are terrific engineering problems as well.
Yeah.
At the same time, we also have financial pressures, NIH funding pressures and things like that. And device development is actually a very challenging space in which to obtain NIH funding because it's not discovery science. Now, there are some institutes are better than others, but you know, it's challenging not only to companies to work in this space, but it's actually challenging for researchers who would love to work in that space to actually do so.
Yeah, I mean, I think I think that's where I come back to, like, the perspective of the industry, I find, is a little bit unhelpful and uneducated, right? I mean, I remember I did nursing before med school, right? So I remember when I was in OR tech, and when you had like orthopedic surgeries, people came in with this nail and this screw and all this kind of, there were millions of things like available, right? And then there was a group in Switzerland that standardized everything. They said screws are like this long, this long, this long. They all have the same diameter.
That's
There's
the
a AO, Aktionsgemeinschaft Orthopädische, whatever it was called. That changed how surgery was done. And like, to not have that for microsurgery, to me, is like hugely ineffective, right? To me, it's the same thought approach. Put it all together, make it work at this and this size. Thank you. It's not that hard, actually. So,
well, I appreciated your talk, as I'm sure we all did. I appreciated the question from Dr. Lena. Also, maybe we planted a seed. Maybe you follow up. Maybe we have a microsurgical think tank.
That would be awesome.
Maybe something AO-like for microsurgery could come.
That would be great. So please, like, email each other. I'd be extremely excited about it. And we have a simulation set up. We can do all sorts of stuff. Yeah. Great.
Well, with that, then I'll ask Chuck to close the session with a clear advertisement of contact information and video recording, so that we're sure to keep the communication going.
Well, okay. Well, certainly, if anyone has translational ideas, either of your own, please contact me. I'll put my email address in here. Please take the survey before you leave. My contact information is there. And if you have any ideas for future talks, please let us know. So with that, we'll thank Dr. Baschat once again. So yes, thank you so much for your time. It was very interesting, and we look forward to hopefully some of these bear fruit in the future. With this is a great idea.
Thank you.
Look forward to seeing the rest of you in future BME-X's.
All right. Thank you.
Thanks all.
Bye-bye.
Bye.
Bye.
Good job, Chuck. Thanks so much.
Okay, you're gone. I'll talk to this F. Thank you, Joni. You can unmute and say, it's great being here. Joni's the one who put all this together. She's Dr. Baschat's admin.
Good, thanks.
And FWM is that guy who I'm related to. Yeah.
I'm going to drop out, but you're a host, so it shouldn't.
Okay.
Oh, wait, are you a host?
I don't know. You got the power.
I'm going to make sure you're a host. I'm going to make you the real host.
Oh.
Not just a co-host. Okay, bye-bye.
I'm the host. Bye, Jeff.